Good evening and welcome to tonight's webinar, Treating and Supporting ADHD Patients. Tonight is session 2 of our two-part ADHD in Practice series. My name is Gloria. I'm a mental health program officer at Central and Eastern Sydney PHN. Joining me tonight is my colleague Christina from the CESPHN events team. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues joining us tonight. I'd like to just quickly introduce our first speaker for tonight, Dr. Martina Gleeson, who is a local GP working out of Caringbah Family Practice. Dr. Gleeson is also the lead clinical editor for Southeastern Sydney Health Pathways and also the regional clinical advisor for Health Pathways New South Wales. Thank you, Dr. Gleeson.
Thanks, Gloria. Next slide. So my main job today is to help you find where you're going to be able to reinforce your learning from Dr. Seth's presentation today. And we've got some good health pathways in both the Sydney and the Southeast Sydney sites. These are the QR codes for you to help you find the health pathways using your phone. If you don't have a password to access health pathways, please contact our team and we'll be happy to send you a password so that you can access. Access is free to any APRA registered medical practitioner. In Australia. Well, actually, and also APRA registered other health practitioners as well. Next slide, please. We recommend that you use the site, either Southeast Sydney or Sydney, depending on where your patient will be accessing services, so that when you get to the request page, the services that are identified are in the area that the patient needs to access. The passwords that you have help you access both sites. So the Southeast Sydney password accesses Sydney and vice versa. Next slide. Just a few tips for health pathways. If you're searching for something, if you go up into the top toolbar there, the top window, and type in what you're looking for and choose the relevant pathway, then you can click on expand all and use that mighty command Control F and type in your search term and it will help you find it in the pathway. Next slide, please. If you're looking for a service and you know the name of the service, you can actually use the search bar to search for the service and it will identify the pathways where that service information is. And then you can click on the pathway to help you find the contact information that you need. Next slide, please. Just a reminder that you can use health pathways for CPD. And so you can use it as reviewing performance if you are looking at how you manage a certain condition and you use health pathways to look up, are you following guidelines? Is there any new information? You can then take a screenshot of the health pathway that you've used, do a quick log in your RACGP account and then claim the time that you've spent reviewing the case and reviewing your performance. So you need to note the steps that you've taken to improve safety and quality if you're claiming EA, if you're claiming RP points. Next slide, please. The ADHD pathways you'll find on health pathways in Southeastern Sydney are listed here. So ADHD in children and adolescents, ADHD medications, and then behavioural concerns in children across 3 different age groups. And also psychometric assessment and paediatric behavioural and developmental assessment for children. We have an ADHD in adults pathway coming through, and also we have autism spectrum disorder in children coming through very soon. Next slide, please. In Sydney, you have clinical pathways in ADHD in children and young people, medications in children and young people, adults, and behavioural concerns in children, and request pathways in child and young adult mental health assessment and non-urgent mental health assessment. Next slide, please. And there's our contact details if you need to get in contact with the program teams. for any advice or for login details. And when you're on Health Pathways, there's that little send feedback button that's right down the bottom. So if you find a broken link, or you found the pathway really helpful, or you think we're missing some information, you can use that button to send us feedback so that we can update the pathway. Thanks, Gloria.
Thanks, Dr. Gleeson. And a copy of these slides will be provided following tonight's webinar as well. So if you want any of those contact details for any of the attendees, they'll be provided after. So thank you, Dr. Gleeson. That was really helpful. So our second speaker for tonight is Dr. Kavita Seth, who you may remember from our first ADHD webinar on the 4th of April. There is a poll at the moment just to gauge how many people attending tonight attended the first webinar, which was around assessing and diagnosing ADHD. So I can see a lot of people had attended previously, but there are some attendees tonight that haven't, probably about a quarter or more. So yeah, hopefully you'll still find tonight helpful. And just while we're waiting on the poll to finish, I would like to introduce Dr. Seth for you that haven't attended the first session, and reintroduce her for people that were here at the great webinar we had last month. So I'd like to introduce Dr. Kavita Seth. Dr. Seth is a senior consultant psychiatrist, addiction medicine specialist, psychotherapist, and senior clinical lecturer at UWA. She's the clinical lead at Fiona Stanley AOD service, the principal psychiatrist at Street Doctor WA, working in Aboriginal health, and has been working at Docatella since 2018. Dr. Seth has a special interest in youth addiction and ADHD, and is passionate about her patients abstaining from substances and transitioning back into work and study with mental health and AOD support. So welcome back, Dr. Seth. Very excited to have part 2 of our ADHD series. So I will let you take the floor. So thank you so much.
Thank you, Gloria. Okay, we have quite a few to go through, so I will start. Just wanted to recap from last session. We did screening and identification of high-risk groups. We assessed and diagnosed ADHD and understood some co-occurring conditions, did some differential diagnosis. We will talk about multimodal treatment, some non-pharmacological therapies, and also a bit of subgroups of ADHD patients as well. So from the last session, we did quickly just wanted to go through the assessment, where it can be diagnosed by a clinician. And one of the questions that the GP polls had was, what is the diagnostic pathway, and can psychologists diagnose? Well, they can, and it will definitely help us in our report and our assessment of patients. It does come with a huge cost sometimes, like some clinical psychologists can charge up to $1,500. And if that, is the case, and they're seeing me for an assessment and treatment of ADHD, then I would say that, that's really not necessary. But if it was someone that they have been seeing their psychologist for, say, CBT sessions, and it just came about that, the psychologist wondered whether the patient had ADHD and did a quick assessment, then even that report is really useful for us. So it depends on the cost, and also what the patient can get out of the report. Sometimes psychologists do autism spectrum disorder assessments, and they go through the strength and weaknesses of the patient, and that could be helpful for the patient in their future therapy with the psychologist. So it just depends on the psychologist, depends on the cost, and if they're already going to see a psychiatrist, the psychiatrist anyway will be doing a full assessment, though it will help. We have to do our own assessment. So I hope we've cleared that. Now we need to do a full mental health developmental medical history. If we have any observer reports or school reports or a letter from parents, for an example, someone that know them before the age of 18, that's quite useful as well, to give us some clues on how they were as a child. If, for an example, if we were seeing an adult ADHD patient, any medical assessments to rule out poor concentration. I do see quite a few acquired brain injury patients, and it's good to know, if they do have one, because it does give us an idea on their prognosis of stimulant medication that, maybe it might help 50% of their concentration, but because they've already got an acquired brain damage, not a lot of their symptoms can be elevated just by medication alone.
Dr. Seth, I was just wondering, are you meaning to be sharing a presentation? Because I can't
Yes.
see.
Oh, I did the share screen. Sorry, I'll just do that again.
Sorry.
Sorry, I'll just share. Sorry. Can you guys see this? Sorry.
Yes. Sorry, I can see it now. It's not in presentation mode.
Now it is.
It is. Yeah, perfect. Thank you.
Okay. Yeah. So this was my first slide. Okay, so that's the assessment. And we normally would, engage parents or carers to further support the patient as well during our assessment. So another question I got from the GP network was, can you give me a very short time efficient assessment tool? And the ASRS version 1 is a very short and sharp ADHD assessment tool, only 18 pages, 18 questions, as opposed to the DIVA, which is about 20 pages. So the DIVA 2.0 is a bit more in detail. You can always ask the patient to do this before they see us. That will help us know exactly where they are struggling in. But if you wanted to just do a quick assessment during your busy day on the clinic, then use this one. And that's more than enough for us to use that to start our ADHD assessment. And it is important that especially for the child ADHD patients, that we know that that the patient is struggling in more than one setting, so either home or school, home and school, or other areas like extracurricular activities, for an example. And we need to assess according to the developmental level, so according to the age. So we wouldn't expect, say, for a 6-year-old or 7-year-old to be more structured as opposed to an 18-year-old in planning and executive functioning. So just bear that in mind when you're assessing the patient. The considerations for ADHD is that we should be aware that sometimes it's not until high school that we see patients with ADHD presenting to our clinic, and that's because primary school they're more supported. Their learning is more supported. The teachers are more involved. But in high school, they're meant to be a bit more independent. So that's when we start seeing more and more ADHD symptoms, particularly around year 9, 10, and 11. And we should be aware of the any compensation strategies that may mask the symptoms. So sometimes they do zone out, but they're just nodding their head because they want to show that they are listening, but actually they're not. And that they've learned to do that to stay out of trouble, for an example. And that we should be aware that some that there could be high rates of substance use, anxiety, depression, or even EUPD as well among the young female population. I always do check whether they have ADHD, because when they have, when they have impulsivity and they are unable to regulate their emotions, that's also ADHD. You can also see that in EUPD as well. So it's good to figure out whether there is something that we can treat more assertively to relieve those impulse that the patient is struggling with. So for psychiatrists, the pathway would be to get a GP referral. Please send another GP referral for follow-up, even if it's less than 12 months. You could do the DIVA or the ASRS. For the child and adolescent, there's something called a SNAP questionnaire as well, which is just a 1-page. And to get some old school reports and old pediatrician reports, if that's available, just do some routine blood tests and ECG and a urine drug screen. Urine drug screen is for ages 13 and above. So why do we need for another referral at the before the 12 months? It's because the 293, which is the follow-up from our treatment plan, it does say in section B that we need to it needs to follow the referral of the medical practitioner that manages the patient. So please send a follow-up before the age of before the 12-month mark. Now, another question from the GP network was the non-pharmacological intervention. So it is important that, while we do place a lot of emphasis on medications, there are non-medication strategy. I always believe in bio, psycho, and social model when we treat any patients with mental illness. So we are interested in the bio, which is we give medication, psycho, which is the psychology aspect, and social is their social life. So a lot of patients do struggle with sleep and insomnia. So it'll be important to give them some tips in good sleep hygiene. They should maintain good diet and exercise. And also, wherever we can support families as well to look after their kids with ADHD. More often than not, most of the, if they have a family of 4 children, quite often a lot of them will have ADHD, and looking after a bunch of, ADHD kids, and if they are not treated, it's a highly hereditary condition, then they will struggle as well. So it's important to try and support the patient. And most of the time when I see patients, when they come in, they go, I was sitting there with the pediatrician and they were asking all these questions, and I could just like mentally tick all the boxes as well. So that's why I've come to see you, doctor. So, it always happens. So we need to bear in mind about the parents as well. In terms of cognitive behavioral therapy, it is more to reflect and understand their own awareness, instill some positive thinking, because most of the time with untreated ADHD, patients, like, even kids, they kind of give up easily because they go, this requires a lot of attention. So it's a high concentration need, a task. So they just give up, like, before even attempting it. So it's important to sort of like instill some kind of confidence and to ask them to, in the whole treatment phase, to see a psychologist so that, they can gain back that confidence and face these developmentally appropriate tasks. They will also benefit from problem-solving skills, self-esteem growth, simple behavioral techniques, and cognitive restructuring. So trying to get them to like understand themselves after they get treated, they do need a counselor or psychologist, preferably someone who is trained in ADHD management, to guide them. So ADHD coaching is a very new thing, and it's very innovative, very exciting. We've got most of the ADHD coaches are ADHD patients themselves, and they have learned and gained experience in healthy coping strategies. So they're not necessarily psychologists. Many do come in with a wealth of knowledge and experience, and they coach patients like a life coach and teach them some tricks of the trade, how to innovate, to do boring tasks, for an example. So medications can get them to be motivated, but sometimes they sort of like lose the steam while they are doing their boring tasks within, for the day. And coaches come up with some really fantastic ideas. So I had one patient that told me, because I asked her, I was like, what did your coach teach you? Like, what are the things that you guys discuss about? And she said there is something called a rolling the dice method. So they write a whole list of boring things that they have to do, like washing laundry, bills, or, a set of maybe a 6 or 7 tasks. And they roll the dice. And if it hits at number 3, they will do the number 3 task first. And in that way they get them a bit excited to just do the task. So these are like, small things that that the ADHD coaches can guide patients and give them the opportunity to sort of like reduce their impact of ADHD symptoms in their day-to-day living. There is a likely cost. Sometimes it's not even Medicare rebatable. Some of them do charge about $120 without a Medicare rebate, but many of the patients just do 3 sessions with them and they learn as much as they can while they're on medication in the first year of medication, and that actually helps them be a bit more empowered for their activities of daily living. So, okay, when we are starting medication, we need to be familiar with the short acting and the long acting kind of preparations of ADHD. Some patients, they can't remember the afternoon doses, for an example, or many kids do not want to present themselves to the principal's office to have their afternoon medication. So it's very important that, we do start with short acting, say for an example, Ritalin or dexamphetamine. That is to check if they tolerate medications well. And then we quickly change it to long acting preparation so that it lasts pretty much 8 to 10 hours and they don't have to do after lunchtime doses, for an example. We need to make sure that it's tailored effectively for the needs of the child. For an example, or the adult, like for an example, I have patients that come and tell me that they don't really need like stimulus to last the whole day. They are just more interested in the morning. For an example, a teacher has told me that she just wants to jumpstart the day. She wants to be more engaged in the class. After lunch, things get a bit easier for her, so she doesn't really need the medication. So, and there are some students that would rather have their medication, say, after lunch, so that, by the time they come home, they get to study a bit more in the evenings. So, these are things to just work with the patient. We need to check any adverse side effects of medications. So the main side effects of stimulant medication, I'll go through the Ritalin and the dexamphetamine class, the methylphenidate and dexamphetamine class a bit later. But just a general understanding, the side effects are usually restlessness because they are, after all, stimulants, right? So restless sleep, poor appetite, and a higher heart rate can happen in the first couple of weeks to 4 weeks. So I do tell patients to just bear in mind, and I do reassure them that it gets better. I will explain to the patient and their family, the support person, so that they can also have a lookout. Rarely patients the stimulant medication can cause mood or anxiety disturbances, or very rarely psychosis even, because it's, after all, a stimulant. These are things that I do explain to the patient, and I do tell them that it's rare, but when it happens, it's serious. So, and they would have to stop it and either go to the hospital or see me quickly. And I think in, say, 10 years of treating a whole lot of ADHD patients, I could easily say thousands, but at this point, maybe 2 or 3 ended up having psychosis. And most of the time, they combine it with medicinal cannabis as well. So that's why we are very, very strict that we would rather patients not have any THC in their cannabis, medicinal cannabis preparation, like CBD oil alone, because combining them can increase the risk of psychosis or anxiety. And medications do alleviate most of the symptoms. Sometimes it doesn't alleviate some habit forming. So for an example, procrastination, sometimes even motivation to do boring things. If people just do not want to do it, no medication is just going to force them to do it. So these are things that, I work with the patient, and that is why it's important to have a psychologist or an ADHD coach to boost them even more in their ADHD treatment. So before we start any ADHD medication, after doing the assessment, we confirm the criteria. We do a risk assessment on the substance use and diversion. We go through the medical history, current medication, height and weight. A cardiovascular assessment will be useful if at all the patients, especially patients have got history of heart disease, we have got or sudden death in the family. Baseline ECG alone is fine, but if we do pick up something abnormal in the ECG, we do ask for cardiologist clearance, because stimulants do increase the risk of heart attacks and strokes. Many studies, they do vary, but I think it's between the 5 to 7% mark. And it does increase over time according to age, lifestyle, diet, has exercise, family history, smoking, drinking history. All of that is multifactorial. And then you've got stimulants as well. So, I do explain to patients that sometimes they get a bit disgruntled if we pick up something abnormal in the ECG, that, we do insist that a cardiologist gets involved and gives us the all clear. A bit more about the cardiology referral, because we've had some in our GP WhatsApp forum recently. It is important if they have a history of congenital heart disease, any sudden death in the family, shortness of breath, fainting, palpitations, and just palpitations that just come on and goes quickly. Sometimes we don't know, whether that's anxiety or a heart condition, but if we pick up something on the ECG, we do want to check it out. Any heart murmur or hypertension. If there's hypertension, it needs to be treated first or monitored, because stimulant medications have been known to increase blood pressure. Okay, now to more exciting stuff. And guess what? I'm so grateful I'm doing this lecture, because even I did not know the chemical compound of methylphenidate and dexamphetamine until I was going through this. So well done to myself. Now I'm a bit more knowledgeable in the biochemistry of the stimulants. So, okay, methylphenidate is a norepinephrine dopamine reuptake inhibitor. So bear in mind, norepinephrine and dopamine. So these two are it's meant to increase the central nervous, the activity in the brain, and it's meant to improve the alertness and focus. So you've got noradrenaline, and you've got dopamine as well. And you can understand why patients, would self-medicate with something like methamphetamine, because that's also increasing their dopamine and norepinephrine level. So it's very linked. ADHD and substance use. So for children, we usually start very low dose, 10 milligram of Ritalin. We start with just half a tablet in the morning, half a tablet for a week or fortnightly. Check the blood pressure, check the heart rate. We ask parents to get a monitor, keep it with them so that they can check. And if they do well, then twice a day, morning and lunchtime, 4 hours apart, 8 o'clock and 12 o'clock. So then they will have to pick up their medication from the principal's office, okay, initially. And I tell parents a month or two, just to check how things are. Then we can quickly change it to Concerta. And whatever the dose, like say Ritalin, if it's 10 milligram, then we will do Ritalin long-acting 10 milligram. If it is one tablet twice a day, it's 20 milligram. We can do either Ritalin long-acting 20 milligram or a Concerta 18 milligram. Concerta is very, very popular among the pediatrician, even though the chemical compound is pretty much the same. But pediatricians do love their Concertas, which comes in 18, 27, 36, 54 milligram. And if they need 72, it'll be 2 of 36 milligram capsule. So for kids, we start really low and we increase really slowly. For adults, it's a bit more quicker. It's 1 tablet twice a day, morning and lunch. And in a week, we can do 2 tablets twice a day. And if at all they would like a long-acting preparation, we just convert it. If they were on 2 tablets twice a day, morning and lunchtime, that's 40 milligram. We do Ritalin long-acting, 40 milligram. And we can give patients 1 or 2 tablets of short-acting Ritalin, just in case it does not last the whole day. So many of them take it at 8 o'clock in the morning, and we expect it to last till 6 p.m. at least. Say they take it at 8 o'clock in the morning, and by 2 p.m. they are extremely tired, not motivated, they're not alert anymore, brain fog has set in, then we do tell them have 1 or 2 tablets of short-acting medication at 2 p.m. to last another 4 hours. That will be on private script. So Ritalin is very particular that one of them has to be a PBS script and one needs to be a private script. So long-acting, we usually do it as PBS, and then Ritalin short-acting would be private. Dexamphetamine, in the US, they call it dextroamphetamine. It's dopamine, noradrenaline, and serotonin transporter. So it's 3. The methylphenidate was dopamine and norepinephrine, which is why dexamphetamine and Vyvanse, they do help perk people up more, improves their mood, because they've got the serotonin transporter as well, and monoamine as well. So that is why it's a bit more potent than the Ritalin methylphenidate class. So for dexamphetamine for kids, we do 1 tablet to try first in the morning, and then 1 in the morning, 1 at lunch. And then if needed, we slowly increase. For kids, if they want to change it to long-acting Vyvanse, we do start with 20 milligram, and then we increase to 30 milligram and so on monthly. Many of them do tolerate between 20 to 30. My 17 and 18-year-old patients, we do go up to 40 milligram, 40 to 50 milligram. For adults, they don't even have to try the dexamphetamine. We can just start 30 milligram just like that. And that's meant to last, again, 10 hours. But if that does not happen and patients have a slump by 2 p.m., we do have, some short-acting dexamphetamine. Both of them can be prescribed on PBS. Okay? So medication of choice from the age of 6 to 18. If we have established that the patient is diagnosed with ADHD, then we do prefer to start first line as a stimulant. Okay, because that's the most effective for ADHD, is the first line treatment. And then we start them with short acting. We may change it to long acting. There could be some cost implications. For an example, I have a patient that told me that, because her son was on Concerta, 36 milligram, she was insistent that if she had Concerta, it would work better. and I offered her the Ritalin long acting, which is on PBS. Concerta is not on PBS if you weren't diagnosed before the age of 18. But she wanted it. She's like, I know that I tried the Ritalin long acting, didn't really like it. If I have the Concerta, I'm pretty sure it will work better. So then she went on private script for Concerta, 54 milligram. Some patients, they hear from their friends as well. Some come to me and say, "Oh no, I do not want Vyvanse. A friend of mine had a very bad experience. I'll just do the Ritalin." Thank you very much. The other side, they will say, "Oh, I don't want Ritalin. I heard a lot of bad things about it. Please give me Vyvanse." So, you just wait with the patient. And I feel like if we work with our patient, there is a research that shows that if we have a good therapeutic rapport, and if we work with our patient and sort of come midway and prescribe what they are comfortable in taking, 70% of the time, the medication will work. I don't know whether you've come across that article. If I do come across, I'll send it to Gloria. It's a very powerful research. So another thing to think about is the celiac. Ritalin short acting has got gluten in it. Long acting does not have gluten in it. Vyvanse does not have gluten in it, and I think dexamphetamine does not have gluten in it. I have to check on the dexamphetamine, but I know the long actings don't have. But Ritalin short acting medication has. There is an implication on that, because if someone wants to be on Ritalin long acting, then they need to have tried short acting first. On the PBS, when we are doing our authority script, it does say, has the patient demonstrated a response to short acting methylphenidate? We have to say no, because they haven't tried it, because they've got gluten in it. So that makes the Ritalin long acting a private script, which is kind of sad. But I have been giving a few patients private Ritalin long acting because they did not tolerate Vyvanse. Okay, it gave them a bit more palpitation. And that's another thing to think about. When you start a stimulant, like say you decide Ritalin or dexamphetamine pathway, right? Some patients come and tell you that they do not tolerate Ritalin or Vyvanse. When you swap them to the other stimulant, most of the time they do work. Don't ask me why. It does happen. So, and I keep, that's what I tell patients. 50% of the time, people will tolerate Ritalin better. 50% of the time, they'll tolerate dexamphetamine, Vyvanse better. I usually start patients on Vyvanse, the adults especially. For kids, I start them on Ritalin. But for adults, no one is going to remember their afternoon doses, especially when they're starting up to be treated for Vyvanse, right? For ADHD. So I do the long acting. Okay. Now, what happens if patients do not agree with short acting, long acting, Ritalin, short acting, long acting dexamphetamine? Then we have to go to the non-stimulant class. And that's when atomoxetine or guanfacine or clonidine can be offered to children and adolescents and even adults. Okay. And they are the non-stimulant class. Atomoxetine is a SNRI, selective noradrenaline reuptake, serotonin noradrenaline reuptake inhibitor. You start very slow and low dose as well, 25 milligram, and you work your way up every month. I know the memes do say within a couple of weeks you can like double or triple the dose. I do not do that, because the main side effect for atomoxetine is stomach upsets, tummy upsets. They get indigestion, they feel nausea, to a point where they just pack it in. And it's such a shame, because it's a really good medication, but it just needs a longer time to get used to it. Sometimes we need a bit of pantoprazole in the morning, 30 minutes before the atomoxetine dose. And that is just to help with the indigestion, that the kind of reflux symptom that they get. Sometimes it can be quite uncomfortable. but it does get better over time. Sometimes it takes 2-3 months, but it's an excellent medication. Guanfacine is Intuniv. Some say it's the long-acting version of clonidine, and that helps to alleviate the ADHD symptoms by calming them down. So it's more of a calming medication rather than for focus and alert. And atomoxetine is the same. It's more of the improving the mood, reducing the anxiety, calming them down so that they don't feel agitated, easily frustrated, impulsive with their ADHD. It doesn't really improve the focus, but it actually calms their thoughts so that they can think better. It's not like a stimulant. A stimulant is like within 30 minutes, bam, they are able to like focus and concentrate. Everything is quiet. This takes time, weeks to build up in the system. Okay. It is also when patients had a psychotic episode, stimulant-induced psychosis as well. That's when we offer non-stimulants as well. For over the age of 18, it's the same as well. Above the age of 65, we do expect a cardiologist to be involved in their care as well, because then, we are weighing the risk and benefits of continuing stimulants in over 65 when risk factors for heart attacks and strokes are at the peak or is getting there. So then we want someone to say, you know what, I've weighed the pros and cons and looks like, you're all clear to continue, which is almost always the case, but the guidelines do ask for it for over the age of 65 to involve a cardiologist. Okay. Now, if at all, another GP poll was, what if, the stimulants, non-stimulants all don't work? What's next? Then we have to really look at our diagnosis again. Is it ADHD or is it severe anxiety? Severe anxiety, the mnemonic that I had when I was a medical student was MRS ICE, Mrs. Ice. Muscle restlessness, muscle tension, restlessness, sleep disorder, irritability, poor concentration, and loss of energy. So poor concentration in severe anxiety, if one is perpetually anxious, how are they going to concentrate on what they're doing? So then it alerts us. Do we have to rethink our diagnosis? And that's when we go back to the drawing board. We say, let's just look at depression, anxiety with some cognitive enhancement medication. So what we have would be bupropion, modafinil, reboxetine, and your SNRIs. Like I said, atomoxetine is an SNRI. So Prestige is really good. I don't really like venlafaxine. I apologize to whoever who likes to prescribe venlafaxine. Coming off is a bit hard. I like Prestige, des venlafaxine is easier and it's safer on the liver as well, especially if patients cope by drinking alcohol because of their ADHD, they just want to calm down, or anxiety. Des venlafaxine is so much more safer. We use that. We use for those who don't drink and their liver is okay, we use duloxetine. Duloxetine, the drug company, I went for their talk one day, and they said someone presented from the US saying that duloxetine, 60 milligram twice a day, morning and night, is a good dose for ADHD as well. So depression, anxiety, and ADHD. So there you go. So you work your way up, 30 milligram every month. Try 30 milligram of duloxetine the first month in the morning, then 60, then again 30 at night, then 60 at night. Apparently it doesn't affect their sleep. If people are keen, like patients, I think especially in the southeastern Sydney, a bit better off, the population is a bit better off, working class, they might even benefit from Brintellix, vortioxetine. It also promises cognitive enhancement. The two antidepressants, other than atomoxetine, the two antidepressants that promises cognitive enhancements are duloxetine and Brintellix, vortioxetine. So try duloxetine first, but it does put a strain on the liver. So that is why those who drink, we do not do duloxetine. We tell them to go for vortioxetine. $60 a month. We start with 10 milligram. I tell them to half it because, it's cost effective. So I say half a tablet for the first couple of weeks, so 5 milligram. And then a full tablet, which is 10 milligram. And then we can slowly increase to 15 and 20. The price is still the same. And Chemist Warehouse. I know we don't want to support the giants, but they do the best prices if patients are on private script and they need to fill their script. Those who can't afford. Okay, so we've tried the non-conventional antidepressant and for ADHD. What are the next the step down now? We're getting desperate, huh? The patient is still not getting better. Then we figure out, what is it that they're struggling with? Is it emotional dysregulation? So is it an EUPD patient struggling with ADHD, right? And constantly anxious and past trauma and everything, right? Then I do lamotrigine. 25 milligram every night for the first week, and you step up. Like week 1 is 25 milligram at night, week 2 is 50, week 3 is 75, week 4 is 100 at night. And then I do the same thing in the morning, 25, 50, 75, 100 for the next 4 weeks. So every week we're increasing by 25 milligrams. So then they are on 100 milligrams twice a day. You just inform them about Stevens-Johnson syndrome, the rash. If it happens, to stop it, find a rash, stop it and go to hospital. I tell them it's something like penicillin. It's not an antibiotic, but it's like that. You see a rash, you go to hospital. And they go, yeah, okay. So then they know it's serious. Agomelatine is for nighttime. If they struggle with sleep, I would rather just give melatonin 6 milligrams, 5 or 6 milligrams. And the modafinil is actually quite good, but super expensive. I think it's like $300 a month. So that is like, if they really, really want to try. So there is a lot of options is what I'm saying. But, you would work with the psychiatrist anyway. You go through the ladder of treatment with the psychiatrist. So for patients with an acute psychotic or manic episode, like I said, rare, it can happen, but if it happens, it's serious. You stop the stimulants and you review. You treat the psychosis, of course. Olanzapine is really good. I know it's not a long-term fix because patient will put on 40 kilos, but if someone is having a stimulant-induced psychosis and they're not sleeping, and they are not as risky to be admitted in hospital, involuntary, or there's no beds, whatever the thing is, 5 to 10 milligrams of olanzapine, and you can step it up to 20 milligrams for a few weeks. It does settle things down so quickly. And then you can think of the alternative. Okay. You could introduce a mood stabilizer. Like I said, I like my lamotrigine, but there are others like valproate, and if at all you think it's bipolar type 1, then lithium, but that's very rare. It's rare. I have never ever treated someone who had a manic episode and thought it was bipolar type 1. It was more of stimulant-induced psychosis. Then you consider an alternative treatment, one thing settled. Okay. You can reintroduce. There are people that I've reintroduced after a year of being stable on their medication and a tiny, tiny dose of Ritalin or tiny dose of Vyvanse, but you put in an application. So psychiatrists put in an application, get an approval, and even they say start really, really slow. Appetite suppression is another major side effect For kids, it brings down their appetite so much that they go severely underweight. So they are able to focus and concentrate, and they are not a menace in the class, but they are in bones. So what do pediatricians say? Give them shakes, give them Milo, whatever they want, nuggets, anything that you can increase the protein level, and some nutritious foods that are tasty. So do that, or give them a good breakfast, egg and toast or what in the morning, and then give them their medication. And then when it wears off, you give them a good dinner. So it's very important to keep a watchful eye. Another growing concern is the eating disorder patients that come to you saying they've got ADHD and they are 40 kilos, 1.7, 1.65, 70 cm. Like, it is a big concern. So then we tell them when they are severely underweight, below the BMI of 18, they are going to lose concentration anyway. They don't have nutrition in them. So they won't be able to concentrate. The cognitive function would start to decline as their weight goes down. It goes down. You see? So then we say that you have to go up to 18 at least. And we write it for the doctors as well, the GP who are interested in co-prescribing. We say below the weight of 50 milligrams, no stimulant. So monthly they come for their scripts. So this is very important because it does shoot down the appetite. So for those who are working or studying after work, for an example, or year 12 students, sometimes you do need to combine long acting with a bit of short acting no later than 3 p.m. 2 tablets of dexamphetamine or 2 tablets of short acting methylphenidate, whatever it is, no later than 2 or 2:30 p.m. If not, they won't be able to sleep. Okay, 3 p.m. Like the moment school bell rings, that's it. You're taking your tablet and that's it. Anything more than that, you won't be able to sleep. And if they don't sleep, sleep is so important. If patients do not sleep, their stimulant medication won't work its best the next day. It's catching up on that lost REM sleep, is what I tell the patients. If you're going to sleep only 5 hours, how is your stimulant going to work? You're going to be so groggy and it's like stimulating you and it's all going to be in a mess eventually. So I say sleep is so important. Either you give them some melatonin before bed to regulate their sleep. Actually, not before bed. 5 p.m. is what a lot of psychiatrists say. 5 to 6 p.m. have melatonin because it takes at least 2 to 3 hours to kick in. So they take it just after their tea, afternoon tea or dinner. If they want, clonidine is really good. Alpha agonist is so good. It just relaxes them. Even for the hyperactive kids who are bouncing off the walls after school, can't sleep. Give them half a tablet or 1 tablet. Just watch out for drop in blood pressure. I tell patients if you feel a bit dizzy, then, maybe just do half first, like try half first. If it doesn't touch any sides, go to 1. Some can tolerate 200 microgram, 2 tablets. So that is really important. Sleep is very important. But, you can combine long acting and short acting. Monitor the treatment, encourage some regular follow-ups. I always ask them, how many % better are you on ADHD medication than before ever meeting me? So many of them say it is night and day. 100% better. They say the windshield, they didn't think the windscreen was so foggy. It's suddenly clear. Suddenly their mind was quiet. You will hear all the success stories. It's so fulfilling. So then, you can titrate and stabilize and you can give them, this is going to be a medication, see the psychologist, check in with a counselor and just, check in ever so often. I see my very stable patients. Like I said, I've been doing Dr. Tella since 2017, 2018. I've got patients that I see every 6 months, or if followed up by a GP, I see them every year. So the considerations is what I have here. Some patients do. So you've got the weight, you've got the cardiology function. Some patients can have developed tics. So especially the young ones, it's important to just keep an eye on it. Okay, clonidine is quite good for the tics. If you feel that, you either change your stimulant, but if the tics still continue, you can give it a break, see whether it gets better. It's a stimulant. It just stimulates, you see, things. So then, tics get more pronounced. So we can either give it a break, watch and wait, or if the parents say, but they're doing so well with their stimulants, can't they just, continue at a smaller dose and we'll keep an eye on the tics? Then you give a bit of clonidine as well. But lowest effective dose is what I tell them. Lowest effective dose, and let's just watch on the tics. Some patients tell me that their sexual function is worse off. I could not believe it when I first started ADHD assessment and treatment years ago. I thought it was a stimulant, it just stimulate everything, but apparently it calms things down so much, it just suppresses their sexual function. So then I tell them, yeah, we just have to weigh the pros and cons, and maybe see sexual health, or see a counselor, figure out what is going on there, like why when they feel a bit better, their sexual urges have stopped. It's just whatever the side effects comes to you, you just have to wait out with the patient. Try a different stimulant. To ask them about non-stimulant, are they willing to wait 8 weeks? But SNRIs, maybe even worse for sexual function. So you just work with them. If they have seizures, because the brain is already vulnerable. So if they had epilepsy as a child, many of them come asking for ADHD treatment because they are just not cognitively all there. And it makes sense because their brain is vulnerable. So then you engage a neurologist as well and make sure that the stimulants are okay. And almost all the time, they'll say, go ahead. Make sure of sleep quality. If there's worsening symptoms, worsening mood, anxiety, any risk of diversions, it'll be good to send the script to the pharmacy rather than their phone, if you're worried about diversion, and weekly pickup. We've gone through the weight. That's just more information if you need. But yeah, it's just more of like having meals and snacks and some yummy treats for kids. Healthy cookies we have nowadays, healthy ones, low sugar ones, made out of dates and stuff. Just give them whatever that that might entice them during the period where they don't have an appetite. Because adults come and tell me they forget to eat and then they start having tremors by 3 o'clock. And they go like, oh my God, I did not have anything to eat. So you can imagine how kids are, right? Kind of scary, right? Like if you don't eat the whole day, and kids can't tell you, right, that something is happening. So, but for adult patients, they go, I really need to put an alarm clock and force myself to eat something. If not, I just get all shaky and all dizzy. And try and engage a dietitian. Maybe they have some really splendid ideas on what kids would love to have, even if they don't have an appetite. Healthy treats, and just measure their growth rate. Some parents do worry that do stimulants stunt their kids' growth rate. Well, we just have to monitor. I mean, that is there is some research that shows that the growth rate does reduce. Still speculative, but we do make sure that we try and monitor them, and also do medication holidays, and then do catch up at that time. So long school holidays or the weekends, give them milk, some really good nutritious breakfast and dinner. Adherence, it's important to give them clear instructions because they are ADHD patients. They're gonna, moment they walk out of the consultation room, they'll go like, wait, what did the doctor just say? It always happens. I always email them. I always email them or I ask them to take notes. I ask them to take notes, clear notes, 8 o'clock in the morning, 11:30 to 12 o'clock. If you need a third dose, no later than 3 p.m. Write it, put it somewhere in your fridge, on top of your fridge. So, it is important to just have it around. And sometimes they need a reminder, like an alarm clock at 12 o'clock to either eat or take their medication. Put the medication next to a kettle if they need, if they have like a morning drink or something, they just can have their medication with it. And make regular appointments. They need to know when their last repeat has been filled. I get so many patients. Even yesterday, I had 2 patients saying they went to their pharmacy and they have run out and they want a script here and now. But, sometimes you're working in the hospital, you're working in another job. You can't do here and now. So you have to tell them, and I do tell them, it's your responsibility. It's in capital in my email. It's your responsibility to know when is your last repeat. Sometimes I tie in my 6-month appointment, but many a times they do cancel that, thinking, why do I need an appointment? And then they go, all right, it was for the medication. It is, when you work with ADHD patients, it's never a dull day. It's never a dull day. So try and give them some really clear instructions. Review the medication, especially with a child, ask how they feel. Sometimes they tell you, I don't like Ritalin, I don't like that medication because it makes me drowsy or sleepy or tired. Then go for dexamphetamine or Vyvanse and see how the effects are. Sometimes parents tell me the child goes to them in the morning going, can I please have my tablet? Because they know it works. It's so empowering. In your review of medication, review the benefits, review any adverse side effects. A lot of the time they say they have dry mouth, so just regular sips of water. And then if you have work with them in terms of like if they have missed dose, just forget about it. Just go, have the next dose the next morning. And the effect of their mental health is that does that help their mood and anxiety, or it's made it worse, or they are more restless? Just review and figure out where to from here. Like, if they still need an antidepressant, despite being on stimulants. Sometimes I see patients where the GP has asked whether apart from ADHD, which the patient wants an ADHD assessment, the GP goes, does this patient actually have depression, anxiety? So then I tell them, the questionnaire, any observer reports and all, and my assessment on the day points towards ADHD. I tell them that maybe if you try the stimulants, it may make your mood and anxiety better. Then you may, because ADHD was a primary cause, they weren't coping, and then that made them even lower in their mood because they are despondent, they have lost their confidence, or it gives them anxiety when someone gives them a set of instructions they don't know how to follow. So, if treating the ADHD alleviates that, maybe their mood and anxiety gets better. So then, I tell them that, look, let's just review. And if you still need an antidepressant, we can talk about it. Yeah. And any need for support, like a psychologist or an ADHD coach, would be good. What if patients come and tell you they do not want to, they do not want to be on medications anymore? Now, you may think this is surprising, but you've got some high school kids that, come and tell you, or you have 40-year-olds that tell you that they were diagnosed when they were younger, they were on medication, but at the age of 13 or 14, they just packed it in. They didn't want to either keep going to the principal's office for lunchtime dose, or their mates told them that they have changed. Their personalities have changed. They're quiet and they don't like it. So whatever the reason is, yeah, and the most common is the early teens. they will come in and say, I don't want to be on it anymore. Just work with them. You can't force someone to take medication, much to the parents' dismay. They go like, well, can you just tell them that they have to have it? I'm like, well, I can tell them the benefits of it, but at the end of the day, it's up to them. And, if if they need medication, they'll be back. They do come back. Sometimes it's kind of sad because they go down the drug pathway and then they come and see you in their 30s or 40s. But there are people that want to, just decide to discontinue. Okay. We just document it. And if we figure out what the side effects are that led to their decision, if we alleviate the side effects, maybe they'll get better. But sometimes they just come in with that notion that that's it. They've made the decision, and sometimes you just have to respect it. So very quickly, I'll do the subgroups and then we can go for questions. We're actually doing well. Okay, so the Aboriginal Torres Strait Islander, we need to cater it according culturally sensitive. Okay, so our work in Street Doctor is, culturally appropriate, culturally sensitive assessments involving the parent or sometimes the elder or a senior is usually involved as well. Sometimes patients have sort of gone down the deviant pathway and started using drugs or, behaviorally disturbed in school or a bit violent, suspended, expelled, diagnosed with ODD. It's all very sad. That's the trajectory of a lot of kids. Yeah. So when it comes with our Aboriginal patients, we sort of try and, explain to parents that being on medication is not going to be forever. Well, if it's forever, it happens. But, at the point, we just do not think that these medications are going to be a permanent solution. It's the temporary one just to calm things down so that people stop judging them, teachers or principals or there he has done this again, he or she has done it again, and stimulants are so empowering because within the 30 minutes, within an hour, they start seeing some change and that we get them on board then. So just really sensitive to them and involve some transcultural if we need to, and put in some non-pharmacological interventions like Aboriginal caseworker or coordinator. We have lots in WA where they work with the parent. But I must say, as the years go by, parents are more and more educated. In fact, the parents come and ask me whether they have ADHD because, they can see it in their child. And so, it's times are changing. I must say that. So, it's good to work with them. But before they become just ODD diagnosis and truancy and drugs and crime, I used to work in the prison system, and a lot of patients I've seen, Aboriginal and non-Aboriginal, they tell me that they wish they turned back the time and someone told them they had ADHD and they were on the right treatment. So, it's very important, especially for child. So that brings me to my next one about the correctional system. A lot of patients have got ADHD there. Oh my God. So, it's very important that we do a comprehensive assessment, involve mental health agencies. It's more of their post-release plan that, they see someone. And I know a lot of psychiatrists and GPs get a bit worried about stimulant medication with patients with past drug history that have drug-related crimes and violent crimes due to drugs and, drug-related and all. Our the Ministry of Health in each state, they do support us a lot, and we actually tell the patient, I'll put in an application and it needs to be approved. So it's not really our it's not really our decision. We would recommend At the end of the day, we put in the application and we wait. So the onus is taken out of us, which is really, really supportive. Supportive for us practitioners, don't you think? So then, they come back going like, you can start the patient on Vyvanse 20 milligram, increase to 30 milligram in the next month. You need to have urine drug screens and weekly pickup from the same pharmacy. They just write the whole thing step by step by step. And you just tell the patient, you just need to follow it. They get angry. Well, I tried and we just need to follow this. If they really want to turn their life around. So don't feel cornered. And you can always involve psychiatrists. Sometimes we involve a second psychiatrist, to help these patients. But because I've got an addiction training as well, that kind of helps. So I'm usually quite firm with the patient and I put in lots of applications. And you know what? Sometimes it gets rejected. You see, gets rejected. They go like too soon. Patient needs to show 6 months of negative urine drug screen, a monthly negative urine drug screen for 6 months, and then send me another application. Just follow it. Okay. And so the substance use disorders, treatment of substance use disorders, we should focus on treating both. It's never going to be one or the other. Okay. So treating both at the same time. So mentally, how they are and what are they using. Sometimes I combine naltrexone for the alcohol users. There is some growing evidence on naltrexone, which is an anti-craving medication, and on cannabis and methamphetamine. We are trialing that even for gambling. It's just an opioid antagonist. So it just blocks the pleasure receptors, basically. So they can't have any codeine or opioid medication. It will precipitate withdrawal in them. But we need to treat both at the same time. And in most cases, ADHD is almost always there. And we should start treatment for both. The use of atomoxetine is really good while we are waiting for a stimulant approval to come through. So atomoxetine 25 milligram increase monthly. In the memes in our formulation, it does say it needs to be initiated by a pediatrician or a psychiatrist. So even if we do the first script, it can be continued and it's really easy. It's after all an SNRI. So I hope at some point they take that out. That we need to write the first prescription. And we shouldn't delay. We shouldn't say, let's just wait for the stimulant approval and then I'll see you. You know what I mean? Like we should try something else. Clonidine is so good. It's so good for cannabis withdrawal as well. For sweating and for agitation when they want to like really come off their cannabis. 100 microgram 3 times a day. It's really good. Combined with some mirtazapine at night. The NDART in New South Wales, the National Drug Research Assessment Center, I think, NDARC in Sydney, they released a research article about mirtazapine, high dose of mirtazapine, and I think it's 60 milligrams for methamphetamine users. It actually reduces the use. So that also can be tried in the meantime. Okay. We have to monitor diversion, of course. So that is why we hardly ever do dexamphetamine, because it's the highest abuse in the community. Long acting is what I normally do. If not, then they just have to do short acting Ritalin. I tell them. If at all, I've known them for a couple of years, a year or two, I might do 1 or 2 tablets of dexamphetamine at 3 p.m., but it's a weekly pickup. I'm like, look, I'm just safeguarding you so that, if things go pear-shaped, it all gets rejected by the Department of Health. I tell my patients, let's just do it. Sometimes we just have to be the boundary, but, we explain to them that we just do not want their stimulant medication to be pulled underneath them, right? So then, we just have to work with them. But I know a lot of psychiatrists would not do short-acting dexamphetamine, period. They don't do it for patients with substance use disorders or recent history of substance use disorders in the last 3 years. Okay. because patients with ADHD and use substances, they use a lot of substances, their tolerance for stimulants actually goes higher. So sometimes you would need to like put in an application for a higher dose of Vyvanse, for an example, more than 70 milligrams. So just bear that in mind. Another question about in the poll was uni support, school support. Okay, so this is the one. You can always put in some a recommendation for reasonable extension for assignments and regular reasonable breaks. I think schools already have that rule. If a patient has been diagnosed with ADHD, they do every 30 minutes. I think it's a 5-minute break, but here in WA, that's how it is. So you just put in a recommendation and they work around it. And for employment as well, if you have an employer that is like willing to look after, willing to have an ADHD employee, then they can go through the occupational therapist as well. And you just put in like, your recommendation and you work with the patient on what they can do and what they can't do. But at the end of the day, it's like you're not really qualified to sort of know what I don't know, a forklift driver or you know, like a manual laborer or, various trades, right? Like you've got no idea what they need. So you sort of like work with the occupational therapist there. You sort of tell the employer to engage one and sort of have a job plan. And these are the useful resources. I know there was another question about it, but we did have Dr. Martina Gleason giving some useful resources there as well. So that's great. That kind of answered one of the questions. There was another question that said about a 9-year-old niece mirror writing. It may be dyslexia, just, it is all very interlinked. When the brain is vulnerable, they do have dyslexia, dysgraphia, autism spectrum disorders and ADHD. They are also interlinked, learning difficulties. So that could be the reason. Fish oil has always been researched on, and it's always been shown that it does improve cognitive abilities, but by how much? Especially for an ADHD patient who is really struggling, using substances to cope, I don't think it's going to do as much. But, for general health, why not? And the rest, yeah, we've gone through that. I'll go through the questions. So
We have
informant
quite a few.
questionnaires. Yeah. So we've got the SNAP questionnaire, which is for children. I can send it to Gloria actually. It's even if you Google SNAP SNAP questionnaire ADHD, it'll come out. It's just a 1-page that can be done for children. Gender affirming care. We do see a lot of LGBTIQ patients that come in. And they do suffer from ADHD. It's just being sensitive with them, and of course addressing them in how they want to be addressed. And the treatment is the same. Adult transgender patients, treatment is still the same as well. They are a bit more sensitive, like our Aboriginal patients as well. It's just working with the patient, and it's not confined to ADHD. It's for all conditions. So the difference between long-acting Ritalin and Concerta, I wish I could be cheeky and just say it's the dosages, but it's seriously, they are long-acting methylphenidate, but pediatricians love Concerta, whether they like the fact that it's at 18 milligram, 27, 36, 54, who knows? Like, long-acting Ritalin does the same job and you just convert. If they were on 2 tablets of short acting, that's 20 milligram, you just convert to long acting Ritalin. But because of the pediatricians, when I see kids, I do short acting Ritalin and I change them to Concerta. 6 years onwards, I think it could be the heart. Like, why is it that we comments from 6 and above? It's because they're developing, and they have found that below the age of 6, above the age of 65. These are like the high risk, you know, when you're starting them on stimulant medication. That doesn't mean they don't start. When you have a patient below the age of 6 that's highly disruptive, highly aggressive, ODD diagnosis, constantly suspended, we do have them. We do treat with stimulants because, you know, you need some, that, you know, the benefits far outweighs at that time, and we just monitor the patient. The role of bupropion is really interesting. As you can, as
Sorry
you know,
to interrupt for 1 second. I'm not sure if attendees can actually see the question. So maybe if we read out the question
oh,
that
sure.
you're answering,
Okay,
is
so
that
they
okay?
can't click on
Sorry.
QA. Yeah, okay, sure.
Thank you.
Sorry. Okay. So the question on why medications commence 6 years and onwards, yeah, below 6 and above 65, physically vulnerable. But that doesn't mean we don't do. We just weigh the benefits and the risk. Now, can you confirm the medication which is good for ADHD as well? So, if you ask me, child, we do Ritalin, and then we move to Concerta. Okay, that's my first line of treatment. For adults, we do Vyvanse because it is long acting. Okay, and if the patients do not tolerate either of this, we swap. We do Vyvanse for kids if they don't tolerate Ritalin. We do Ritalin for adults if they don't tolerate Vyvanse. And if all ends fail, I was going through the non-stimulants and then the antidepressants and then the mood stabilizer PowerPoint slide. How long does the benefit of stimulants last? Yes, years. Well, how long is a piece of string? So okay, last in the day, it at least 10 hours. If it's shorter, then I was telling you 8 o'clock to say 2 o'clock, then you do a couple of short acting stimulant to last a bit longer. Now, over the years, if they don't do some holidays, if they don't stop over the weekends, they don't stop on school holidays or, you know, working people, I tell them, do not take your medication every day. If you ever need to on Saturday or Sunday, just take 2 tablets of your short acting at 10 o'clock. So the ones on dexamphetamine, I say, take 2 tablets, which is 5 milligram each tablet. Take 10 milligrams at 10 a.m. and just do whatever you have to around the house. Don't take your Vyvanse. That sort of reduces the tolerance. Now, it's still kind of speculative because a lot of people say, like the drug companies go, oh no, there is no tolerance. Like, you know, you can have your medication every day. But practitioners like us, we have patients that come in going like, at first 30 milligrams was a beauty. After a month, I can't feel it. So then I go, you know what? You do have risk of tolerance. We will go up the dose, but you need to have breaks, is what I tell them. Can patients drive when they are on medication? Oh, I don't know how to explain this. They can work, they can drive, they can have a blessed marital life, they can look after kids, they can do a lot more than they did without medication. Their life is like night and day, 180-degree turn, U-turn. They are so good, so good. They go, so, you know, they can do. Yeah. How common is depression? So if they are severely depressed and suicidal, you give them a stimulant, it increases their energy levels, and then their suicidal ideation is there is risk of completing a suicide. Okay. And it's the same for antidepressant as well. You have someone with severe depression, suicidal ideation, low lethargy, low energy, start taking antidepressant, got a bit more motivation, suicidal ideation is still there, right? So that's the theory behind that. So yes, it is present, it is quite common, but would they act on it? Do we have a suicidal plan? We are starting on a low dose anyway, and we are following them up closely. So, you know, I haven't had, touch wood, anyone completing on a suicide, but you know, we have to take that in mind. We have to treat it seriously. Okay. And that is why you would do low dose and slowly increase and see them more regularly. Okay. Now, do you mean the medication should be lifelong? The diagnosis is made, the medication has been started. So yeah, lifelong. I tell you, there are many patients that would take medication until they retire. And I have some patients coming and telling me after they retire, they go like, Doc, just because I retire doesn't mean, my life has stopped. I still want my ADHD medication. I still have a lot of things to look forward to. So I'm like, well, then see a cardiologist. I'll give you your script, 6 months, get a cardiologist to say all clear, will continue. All right. So could be lifelong. I've got some patients that come to me at 55 and they go like, you know what, it's time I stop. It depends. Some of them get promoted to a point where they have so many delegates that will do their work. So, it depends. Do people develop dependence tolerance, and how do you manage that? Yeah. So I do tell them Saturday and Sunday. I over time I work with them a plan. If they are Monday to Friday, I say Monday to Friday you can have your Vyvanse and a bit of dexamphetamine or Ritalin long acting with a bit of Ritalin short acting, but you would need to at some point in your Monday to Friday figure out, can you just let go of the short acting Ritalin so that you just have long acting that day only and keep your combination for extremely long working days. Saturday and Sunday, just have 2 tablets of short acting and be done with it. If you can, 2 tablets of short acting on a Saturday, none on a Sunday, wash out, start again on Monday. If they come and tell you they can't do it for all reasons, you sort of say, well, don't come and tell me you're going to be tolerant in a few months' time. Like, we have to give and take. We have to have a compromise. We need to come in the middle. So that is important. Yeah, we can we swap directly from venlafaxine to desvenlafaxine? Yeah, we can. Yeah, it's okay. So it's good. I prefer desvenlafaxine rather than venlafaxine. It's too activating. It's like citalopram and escitalopram, it bypasses the liver, so it's a lot. Yeah. Any other questions?
One more has just popped in, and then maybe we'll finish up after that because I know we've gone over time, but it just has asked what is involved in a GP becoming a prescriber.
Prescriber, yeah, you can just apply through the script check New South Wales. And also, if you go on your website for stimulant prescribing New South Wales, there is a form there as well. But a lot of GPs in not only in New South Wales, they do engage us psychiatrists to do the initial assessment and treatment because it's a lot easier. And they do take over prescribing. But we do have quite a lot in different states, like in Queensland. Here in WA, we have a lot of ADHD GPs. So they do the assessment, the thorough assessment, observer reports, blood tests, urine tests, ECG, and they put in front of a psychiatrist like myself, and I do the go ahead and do the co-prescribing form, and they prescribe the medication.
Just clarifying, it's Safe Script New South Wales, not Script Check. Yeah.
Oh, Safe Script New South.
Yeah.
Sorry, yeah, it's Script Check WA. Yeah, Safe Script New South Wales. Thank you so much, Dr.
That's
Jason.
okay.
Yeah, yeah.
Lovely.
An ADHD GP in New South Wales. I think there are growing more and more GPs are becoming more and more experienced in Australia. I don't know whether we can, Central Eastern Sydney PHN will be able to guide on the GPs that have interest in ADHD, but most often you would actually find your friend or your family member. They'll say, go to this GP, they know how to treat ADHD, and it just spreads by word of mouth. But it's good to even ask your GP if they know any local GPs that are interested in ADHD prescribing, because they do co-prescribe and co-manage with a GP, with the main GP. There are other GPs that sort of like co-manage and they prescribe the ADHD medication, and that's increasing as well.
Okay, I
Thank
think
you
that is
so
the last
much.
question. Thank you, Dr.
Oh,
Seth.
yes.
That was great. We do have one more question, but I am conscious of the time.
Yeah, this is really easy.
Um,
So, okay, I'll just do this and then we'll bid farewell. How to prescribe the medication after the psychiatrist has agreed for share care, it will be in our plan. We will say medication, please continue Vyvanse 40 milligram every morning. That's it. And Charles, you can just prescribe that medication. And sometimes when we give the report, we are not meant to sort of say you can increase or decrease. It has to be that dose. And if the patient complains and says, "Oh, it's not working anymore," just send us a referral, and we will review. If we have to add on a short acting, we will say, "Please prescribe Vyvanse 40 milligram in the morning, dexamphetamine 5 milligrams times 2 tablets at 2 p.m." Very easy.
And then the logistics are you log into SafeScript and you click on the authorizations part of SafeScript and you put in the application online and you enclose a PDF copy of that psychiatrist letter that you've received. And if you've got the backup psychiatrist letter, you'll often get the approval. Actually, I think it's called approvals rather than authorities. You'll get the approval within hours. It used to take 2 weeks or a month.
Yeah.
It's now coming through in hours. So that's great.
In WA,
Thank you.
3 months.
Oh.
Yeah. We are working very hard.
Yeah,
Yeah,
I think
isn't
they've
even-
automated it.
There isn't even a link on the top right-hand corner in our script check WA. Yeah.
Oh,
Anyway, thank you
that's
so
good to hear.
much.
It's so efficient. Yeah, thank you,
Yeah.
Dr. Seth, and
Good
also
on
thank
New
you,
South
Dr.
Wales.
Gleason. Thank you both. It was a really interesting webinar, and thank you everyone for all of your questions and engagement. I hope everyone found it useful. And just a reminder to complete the evaluation survey so we can issue you with a certificate of attendance. Thanks, everybody.